Adesso vi faccio ascoltare il dottor David Amron dalla California e poi ci possiamo dedicare agli ospiti che sono qui con noi oggi.
Hello everybody, Dr. David Amron. Ciao. Thank you so much for having me at the LIO Lipedema Congress in Italy, speaking by video presentation. Next year I had made a promise that I plan to be there in person to meet all of you and to speak next year, so I very much look forward to it. Anyway, we're going to begin this conference or this speech. I hope I speak slowly so you can understand me. The talk is about lipedema in the United States and my experience and my technique of how I go about treating patients. I have no disclosures. My experience is that I am a board-certified dermatologic surgeon since 1995 and have been in practice 25 years. My practice has always focused on liposuction. It's the only surgery that I do, all different aspects of it, from cosmetic patients to very advanced, complicated patients, a lot of revision surgery. I've been doing surgery on lipedema patients for over 20 years now. I have done over 3,000 lipedema patients, surgery on them, and my practice currently, over the last many years, is dedicated to lipedema. I do several cases every week of lipedema surgery. I am the medical director and founder of the Roxbury Institute in Beverly Hills, California. I have established a program at the Roxbury Institute called the Advanced Lipedema Treatment Program, ALT, and has many different components to it, from diagnosis to medical therapy, to nutritional counseling, to decongestive therapy, MLD therapy that we do in-house. Of course, the lymphatic-sparing liposuction surgery that I perform. We have plastic and reconstructive surgery by plastic surgeons that I use in the center to do the reconstructive work on patients that need it. We do certain aspects of stem cell therapy if it's indicated, primarily orthopedic stem cell therapy or on certain patients with a lot of inflammation. And of course, pre and post-surgical IV therapy. So one of the first things is liposuction for lipedema is not your typical liposuction. It's not the same as cosmetic liposuction for a number of reasons. To begin with, lipedema, as we all know, is a disease. It's a condition, lipedema, and it must be done by a surgeon who understands that this is a disease and many different aspects of it, from the pre-care to the post-care. Lipedema also, one of the differentiating things is you are treating very complicated areas with lipedema, not your typical areas that liposuction is done. In the United States, probably 3% of surgeons do liposuction in calves and ankles or forearms, maybe less than that. So it commonly, as you know, lipedema involves these complicated areas, calves and ankles, many times even forearms. Lipedema is a circumferential disease, number 3. It's very different. It's not just certain areas. It wraps around, as we talk about, entire cosmetic units. Patients tend to bleed more and bruise more with lipedema. As we know, bruising is one of the symptoms of lipedema. There's also an increased risk in lipedema patients of DVTs. Many times patients have hypercoagulable states. DVTs are deep vein thromboses, which have to be considered. We'll talk about that in terms of how I care for that. Lipedema patients have reduced skin elasticity. They have many times hypermobile joints and hypermobile skin. A condition called Ehlers-Danlos, as you may know, commonly goes along with lipedema. Finally, the lymphatic-sparing approach is always important. Respect for lymphatics and how to approach it, we'll talk about that also. And finally, fibrosis is a very important differentiating factor. Lipedema patients have a lot of fibrosis. Fibrosis is a fancy term for scar tissue. It's a topic I spoke about this past year at FDRS, the meeting in Baltimore. That is very different in lipedema patients. So the goals for lipedema surgery in lipedema patients is primarily 2 things. Number 1, it's the treatment of the disease. For the symptom reduction, the maximum prevention of the disease itself. So that's one component. And the other component is the cosmetic improvement. Lipedema should be done in a lymphatic-sparing way, the maximum fat reduction of the lipedema fat, and also the maximum decongestion and release of fibrosis. And every patient, there's a spectrum, and as you can see in the bottom of the slide, I made a little line graph of, on one hand, it's patients who care primarily about cosmetic improvements. On the other hand, patients who care more about disease treatment and prevention. Most patients, of course, it's a combination, and the surgery should maximize the cosmetic improvement and the disease treatment of lipedema. So this next slide is my representation of all the dizzying terms, at least in the United States, for liposuction. Many different names on it, many different devices and tools and techniques that are being marketed and branded. It gets to be very, very confusing for the patient to understand, at least. So I'm going to try to make some sense of this for lipedema specifically, to give you a better understanding. The talk is going to clarify, hopefully, 3 areas of confusion. Number 1 is anesthesia. There's a lot of discussion about that. Some surgeons like general anesthesia, some like twilight, local anesthesia, but how are you approaching from an anesthetic approach? The second one is what I'm calling the anatomic approach. How are you approaching it in terms of body parts and areas of the body, which we're going to talk about? And the final thing, which is a lot of discussion about, is all the different tools that are used, whether it's wall or Vaser, whatever it is. A lot of discussion about that. So to begin with, in terms of anesthetic approaches, you are either approaching, as far as I'm concerned, from a standpoint of doing a patient under general anesthesia, where the patient is intubated, typically loose muscle tone being rolled around. We're going to talk about that, using intubation and gases, or you're doing it in a variation or a version of what's called tumescent local anesthesia, either without an anesthesiologist with mild sedation, or with an anesthesiologist, where the person is put under what's called twilight, or monitored anesthesia care, or conscious sedation. So in my practice, we'll talk about 60% of my patients are done, first of all, almost all my patients are done avoiding general anesthesia. And about 60% of my patients are done under twilight, 40% under twilight with an anesthesiologist, and about 60% currently with purely local anesthesia with mild sedation. And then also, is the surgeon doing it in an accredited surgical center, which I prefer to do because it's an operation, or are some surgeons doing it in procedure rooms, which can be fine as long as it's properly equipped. So the advantages of local anesthesia, avoiding general anesthesia, fall into 3 categories. Number 1 is safety. I didn't go into a lot of detail about this, but there's a lot of research and papers many years ago have shown that liposuction, specifically under general anesthesia, has a much poorer safety record. Around 1 in 5,000, the mortality of liposuction under general anesthesia. There was a study done many years ago, 500,000 patients, showing quite a high mortality rate of lipo under general anesthesia. Increased risk of clot formation. The surgeon potentially can traverse unsafe areas and damage things. So safety is one benefit of local anesthesia. The next one is faster recovery. Under local anesthesia, the surgeon really has to stay in that safe plane between the skin and muscle, and should not be and cannot be traumatizing other things, like even muscle, which causes a lot of bleeding. So generally, the recovery is much faster under local anesthesia, or versions of local anesthesia. But the most important reason is really results, getting the best results. And we're going to talk about this. General anesthesia, again, the person is intubated, lying on their back, being rolled around, loose muscle tone. To me, it's a technical disadvantage doing liposuction on a patient under general anesthesia. I care a lot about positioning, the patient tightening their muscle up, especially with lipedema, because you've got a circumferential disease that wraps around entire units. And especially if you're using a circumferential approach, which I'm going to talk about, it's important to have the patient assume positioning. So results are the third factor that's important in terms of local anesthesia. So anatomic approaches. I've realized that around the world, surgeons that are doing lipedema surgery are either approaching it by one of three ways. I talked about this, I think, 2 years ago at FDRS. They're either debulking areas and spot treating areas that there may be more involvement, more fibrosis in, and giving the patient some improvement. Can be in cosmetic improvement or disease treatment improvement by spot treating or debulking areas. Another common approach is what I'm calling the strip approach. which is probably maybe the most common approach, where the surgeon is doing parts of the extremity. Let's say the legs, for example. They may be doing the whole middle part of the legs, or doing the whole lateral part of the legs, or doing the front part, or doing the back part. So that's another common approach, doing a strip approach. And then the third is what I've really developed, that I'm calling the circumferential approach, where the surgeon is going around the entire unit all at one time, and blending everything. I prefer that. We're going to talk about how I utilize it. But again, lipedema is a circumferential disease. I feel it's better to follow that disease fat circumferentially, but also from a cosmetic standpoint also. So the next slide goes into the idea of cosmetic units. I've always realized that with liposuction, just in every patient, whether or not it's lipedema, you have to understand the body from a standpoint of not only balance or proportion, but also cosmetic units. And with lipedema, it's that way. When I look at a lipedema patient, I'm looking at their cosmetic unit in its entirety. And I break the cosmetic units into the circumferential calves and ankles from the knee down to the ankle as one cosmetic unit, the circumferential thighs as another cosmetic unit all the way around, the circumferential upper arms, the circumferential forearms, and then the pelvic girdle, which is the lower abdominal area and the hip and upper buttock area as it wraps around. And this is a representation of the percentage that really can be done safely at one time in a surgery. So when I do the circumferential calves and ankles, that's 50 to 60% of what I can do safely, not only from a fat removal standpoint, primarily from a lidocaine standpoint, that I don't exceed 55 milligrams per kilogram of body weight. When I do the circumferential thighs, it's 90 to 100%. I typically can never do more. It's a very large surface area. Forearms are very small surface area, 10%. So these are the way I look at cosmetic units. How I group the cosmetic units at the bottom of the slide is a common grouping. Typically, I'll do the calves and ankles in their entirety at one time, and I will usually do the upper arms, sometimes the forearms along with that as my 100% of one full surgery, which might be a 4-hour surgery. When I do the circumferential thighs, that becomes a separate surgery at a separate time all the way around. The hip and upper buttock area is about a half a surgery. Typically, surgeries are done about 4 weeks or more apart in between surgery in the average patient. The next slide goes into tools. And again, like I mentioned, a huge discussion about all these different devices. And the top of the slide, you'll see the listing of the different common devices. Water-assisted liposuction is a common tool that's used. Vasor's a common tool, at least in the United States. We like to use Vasor in certain ways. Power-assisted liposuction is a vibrational device that works in a certain way, and I have a video that's going to show you this in action in the operating room. Laser, another smart liposuction, is another common tool. And then there's some tightening tools that are out there. J-plasma, Renuvion, radiofrequency, body type. So this is my experience in how these tools work and where they excel. Wall, for example, to me, I use it, as you'll understand, as a tool to tumesce, to put all the fluid in. I find that wall is not great by itself in terms of either the sculpting, but primarily the release of fibrosis. I don't think wall is so great with that. Vasor, I think, is very good in terms of release of fibrosis. Not actually quite as good as a mechanical release, which I call vibro dissection. But it's good for emulsification, release a lot of surface fibrosis, and one of the reasons why I like it in terms of cellulite improvement. Power-assisted liposuction, very good with fibrous release, good for emulsification. Laser, I primarily use laser, smart liposuction, when I'm treating a Derkham's patient. It's very good for this high peak energy to emulsify those Derkham's nodules, lipomas. And then radiofrequency, body tight, excels in terms of further tightening of the skin underneath. The next slide is a quote that Dr. Stutz, as many of you know, he actually might be there. If you are, hello, Dr. Stutz. We've spoken at many of the conferences, at least in the United States, alongside each other. And he made a statement years ago, I think it was in 2015, that just stuck in my mind, that it really is true. They are all metal wands under the skin. And it really is about how the surgeon, their judgment, their experience, or their understanding of things, how they go about it. It's much less important about the tools that are being used. So let's go into a little slide, a little video presentation, a couple minutes of a demonstration of these different devices in the operating room. So this little video that was made last year of me in the operating room showing some of the devices. This is first step, remember, is water-assisted liposuction, which I use to tumescent. Again, you can use it for the entire surgery. This little animation of it you'll see. It's basically a device that squirts out water and air, and you can also use it for suction too, called body jet. I discovered when I first got this that I don't love it for a liposuction tool, but I do love it as a tool to tumescent. I think it does a beautiful job with it. This is Vaser, and Vaser is ultrasonic energy, and it's done through these little ports, rubberized ports to protect the skin, because you can burn the skin with Vaser if you're not very careful with protecting the skin. But again, you want to be in that subcutaneous layer of fat between the skin and the muscle always. This is me doing circumferential calves and ankles, working around the ankle area with a very small Vaser tool. This is supposed to be smart lipo, but it's not. This is still Vaser that I'm doing, but that's a little schematic or animation of smart lipo. And smart lipo, I really just use primarily now for Durkheim's disease. I find that the high peak temperatures do very well with it. This is body tight, and body tight is radio frequency, and it's monitoring the temperature both internally and externally. And I use it purely for skin tightening, purely for cosmetic purposes. As you can see, it's a very good technique, but I'm counteracting the skin along with my technician, making that a tight sheet so that you're able to move through it. You've got to be very careful with body tight and have a lot of respect for it. If you touch the end of it, you can burn the skin. And this is power-assisted liposuction, which actually I do in a two-step process. I now do more of a debulking step right after water-assisted liposuction before Vaser, and then just before body tight, I do a fine sculpting using power-assisted liposuction, and you can see the very pure fat that's coming out. So the next slide is a very brief discussion of my approach, technique, and tools. I'm going to be giving a talk on my circumferential approach and going into much more detail about it. And that's what I will talk about next year, most likely in person when I'm there. But this is a brief synopsis of how I go about doing things. So my anesthetic approach, like we talked about, I almost never use general anesthesia. It's very rare, even though I can do it at my center. 60% of patients are done with mild sedation under tumescent anesthesia without an anesthesiologist. 40% are done with moderate anesthesia in what's called twilight. Patients that are complicated medical histories, certainly. Patients past the age of 55 or 60. Many complicated patients, so a lot of your larger, more complicated stage 4 lipolipedema patients. And finally, just simply nervous patients. Patients say, Dr. Amron, I want to be asleep, I don't want to know what's going on. Those patients will be done under twilight. The anatomic approach. So in my practice, 90% of my approach is the circumferential approach that I develop. When I do the calves and ankles, I do it in its entirety and blend everything at one time. The thighs, similarly, how I go about doing things. I think it's an excellent approach, not only from a disease treatment standpoint, but absolutely from a cosmetic standpoint. But it's a much more complicated approach. And we'll talk about that more in detail next year. 10% of patients I don't do circumferentially. I feel their tissue is not going to handle it. They have too much congestion and fibrosis. Typically your later stage 3 lipolymphedema patients, stage 4 lipolymphedema patients. But again, somebody can be stage 4 and not have a lot of fibrosis. And I might do them circumferentially all the way around. So I make that judgment call, but about 10% of my practice, I use a semicircular approach. And finally, in terms of tools, so I have a stepwise way of going about doing this. It kind of goes through step 1 through 6. I start by putting a fluid in, what's called tumescent anesthesia. It's an important preparatory step to prepare the tissue to create essentially a bloodless field. I do like Walford. I think it's an outstanding tool to tumescent, but then after that, wall goes away. Step 2, I do a step of, I hate to use the word debulking because it implies you're just debulking, but it's a deeper level of removal of fat with power-assisted liposuction, but I also use it mechanically to vibro dissect and release a lot of the fibrous tissue. Step 3 involves VASER, which is ultrasonic energy. When I've thinned that layer of fat down to emulsify the fat further and further release a lot of the fibrous attachments underneath the skin. Step 4 is I go back now with some fine sculpting with smaller cannulas and perfect the sculpting, again using power-assisted liposuction. And then finally, if I decide I'm going to use body tight or radial frequency in those patients that could benefit from it, that's the final step. And then if patients have DIRCMs, I may also employ using smart lipo to emulsify those fibrotic lipomas or nodules. The average number of surgery I do on patients is I do a complete correction in the average patient in 2 surgeries. Typically it's calves, ankles, and arms together. Circumferential thighs a month later in that same patient. About 5 to 10% go into a 3rd surgery if it's very involving the upper buttock area, and maybe 1% have a 4th procedure done. That's very rare. And then in terms of peri-surgical considerations, I listed a few out here. Some pre-surgical things I do on every patient, medical clearance. Certain patients, if they're very congested, stage 4 lymphedema patients, they have a lot of fibrosis, I might want them to do pump therapy, decongestive therapy prior to surgery. If they're soft and they're stage 1, stage 2 patient, maybe even early stage 3, they've got very little fibrosis, I don't typically have that patient do decongestive pre-therapy. They do prophylactic antibiotics for 5 days. And in terms of post-surgery, some considerations. Several years ago, I began to use Lobenox on every patient 24 hours after the surgery for 5 days to prevent any chance of DVT formation. Surgical compression garments generally stay on for 24 hours a day for 1 month. And if the patient is decongesting well, they switch over 12 hours a day after that. Typically with decongestion, most patients decongest in a linear fashion. Some patients that have delayed decongestion go the other direction. They can many times become more congested for the first month or 2. That happens about 5 or 10% of patients. Those patients will be much more aggressively treated with decompression therapy afterwards. MLD therapy on the average patient 2 to 3 times a week for several weeks. I currently bandage or wrap about 10% of patients that are more advanced patients after the surgery. Patients are instructed to start ambulating the next day, taking walks and gradually increasing those walks. Generally, it's about 3 or 4 weeks till they get back into an exercise routine. This is one of my quotes, the next slide, back in 2004. Today, many physicians rely heavily on the latest technologies and gadgets to achieve great results, but I'm a big proponent of putting more focus on the doctor's skills, their hands, experience, judgment, and medical artistry. It's not about trusting the machine, like Dr. Stood said, but about the physician behind it, and I absolutely still feel the same way today. This is an example of a patient I did many years ago in 2 surgeries. Some of you might have seen this result. It is a very good result. This is actually only done just a few months after, and she further improved. But the point I want to make about this is this was done many years ago, before wall, before even power-assisted liposuction. It's just mechanical lipo done by myself. No VASER, no smart lipo, no body tight. Just well done circumferential liposuction. And this is a great example of it's much more about how the surgeon does things as opposed to exactly the tools they're using. Some obligatory before and afters for you to look at, showing calves and ankles. This is another patient, very impressive result on the upper right of the circumferential legs done. A view from the side showing the circumferential approach. A much more advanced stage 4 patient that had a great improvement, done in a total of 3 surgeries. On the lower right, who's now going to have reconstructive stuff done months later when she comes back here and should look fantastic. This is an old actress from Puerto Rico. And then finally, I want to thank all of you for inviting me again to speak at your Congress. I'm honored. This is my lovely family, my little group and gang back in Los Angeles. And I look forward to seeing all of you next year, most likely with my family. Ciao.